All right. Hi, everyone. Welcome to CHSS's third GBM speaker session. This week, we'll be hearing from Dr. Christine Peat. Dr. Peat is the director of the National Center of Excellence for Eating Disorders and an associate professor of psychiatry at UNC. She completed her undergraduate training in psychology at the University of Arizona, and she earned her master's degree and doctorate in clinical psychology at the University of North Dakota. Her internship was in behavioral medicine at West Virginia University, after which she went on to complete her postdoctoral fellowship in eating disorder research at UNC under the directorship of Dr. Cynthia Bullock. As the director of NCEED, Dr. Peat is focused on broadly disseminating education and training on eating disorders to healthcare providers across a variety of disciplines. Her research centers on eating pathology across the spectrum, but with a distinct focus on binge eating disorder. She is particularly interested in the intersection between obesity, bariatric surgery, and eating pathology, and investigating physiological comorbidities associated with eating disorders. Dr. Peat is also a licensed psychologist in North Carolina, and as such, treats eating disorders across the spectrum with a primary focus on binge eating. Given her background in behavioral medicine, she has also established clinical services in GI surgery, where she provides both psychotherapy and behavioral medicine interventions to this patient population. In addition to her clinical and research responsibilities, Dr. Peat is also a clinical supervisor for predoctoral psychology interns, psychiatry residents, and mentors undergraduate students. Dr. Peat will be presenting an overview of eating disorder diagnoses and their treatment, with an eye toward public health impacts and the role of frontline healthcare providers. If y'all have any questions throughout the presentation, you're free to ask them in the chat or wait till the end. Dr. Peat, we are so excited to hear from you tonight.
Great, thanks. Good evening, everybody. Thanks so much for having me tonight. And I'm hoping to present just some general information about eating disorders and kind of thinking a little bit about the impact that they have on general public health and the ways in which you as aspiring healthcare professionals or folks that are interested in healthcare fields might be able to play a role. So I think I am able to move forward with the screen. Hang on one second. So I am not super adept at controlling somebody. Oh, here we go. Okay, so if I want to advance, do I just click? Would one of you let me know?
Yes, you should be able to just click forward.
Okay, great. Thank you. So let's see here. All right, so let me go back one slide if I could. So just to kind of give you an overview this evening of what we're going to talk about, I want to make a few points. So the first is that eating disorders are serious conditions, but they're often underdiagnosed and undertreated. We also know that there are some very real barriers to care that actually create a real crisis for those with these conditions. And primary care providers and other frontline providers can play a really crucial role in both detecting eating disorders and also managing them over the long term. So we're going to kind of touch on all of those things here this evening. So I'm going to first start by talking about these conditions that are really significantly underdiagnosed and undertreated. So first, I'm going to start with what we kind of have as a stereotype about eating disorders. So the pictures that are presented here, I think, are often kind of the visual that people have when they think about an eating disorder. And I think that unfortunately, these stereotypes are ones that have really hampered the ability for people that struggle to get adequately detected. Because if you don't look like this, you might not think that what you're experiencing is an eating disorder. Or if you don't fit the model of kind of what's presented throughout pop culture and even some on some of these, talk shows that take place, if you don't fit that model, you may think, oh, well, then I don't have an eating disorder. This must not be what I'm going through. But in reality, we know that eating disorders tend to look more like this. Folks that struggle with eating disorders or disordered eating are your friends, they're your neighbors, they're your family members. They're people that live in every size body possible. They're people that are of every race, every ethnicity, every sexual orientation, and every gender identity. We know that eating disorders don't discriminate. And the more that we adhere to these kind of old-fashioned stereotypes, the less likely it is that folks get detected. So I think it's really important that folks are kind of clued into this idea that eating disorders are common and that they happen to folks kind of across the spectrum. So I think it's really timely also that we're talking about this tonight. We are smack dab in the middle of National Eating Disorders Awareness Week, which kicked off on Sunday. So I'm really enthusiastic that you all asked me to be here to talk a little bit about this tonight. I'm going to kind of quickly go through some of the diagnostic information, not because I expect you to sort of memorize all of this, but just to kind of give you a sense of when we talk about eating disorders, what are the types of conditions that we're talking about? So the first is anorexia nervosa, and this is one that most of you are probably familiar with. The defining feature of this particular disorder is one in which individuals have an intense fear of gaining weight, such that they end up really severely restricting how much they eat, which then leads to either a significantly low body weight or a really precipitous weight loss. There are two subtypes that are, sort of encompassing of the diagnosis. One is the restricting subtype, where folks are really just engaging in this severe dietary restriction. The other type is this intense fear of gaining weight, a low body weight, in addition to experiencing binging and purging episodes, which we'll talk about here in a minute. Anorexia nervosa is the least common eating disorder out of all of them, affecting roughly 1% of the general population. But I want to note there, when I say 1%, that means meeting every single diagnostic criterion for anorexia nervosa. So there are lots of folks that might fall short of that, but still definitely merit treatment. We know that typically there's an adolescent onset, but it can be earlier and also can be later, and it does tend to have a chronic course. Bulimia nervosa, on the other hand, has a defining feature of these binge eating episodes, in addition to what we call inappropriate compensatory behaviors. So let me unpack a little bit of this for us. When I say binge eating, I don't mean just sitting down and eating a lot of food. I think that's something that is common for so many of us, whether it's been during this pandemic, maybe it's the holidays. If that were the only criteria for having a binge eating episode, then everyone probably at some point would have had binge eating. So when I say binge eating, what we mean really is this clinical feature of not only eating a large volume of food, but also this subjective sense of feeling totally out of control while you're eating. I could not stop eating even if I wanted to stop. We have some folks that describe it almost like a dissociative experience, sort of like they come up out of their bodies and they feel like they don't have control. Or some people describe it almost like as a car rolling downhill without brakes. You just can't stop yourself. So that really is one component of bulimia nervosa. The other component is something called inappropriate compensatory behaviors. And those are going to be things like self-induced vomiting, laxative, diuretic, or diet pill abuse, compulsive or driven exercise. So it's sort of this pairing of a binge eating episode along with one of these kinds of behaviors. The prevalence is more common than anorexia, affecting approximately 1 to 2% of the general population. Again, recognizing here that that's threshold diagnoses, much higher if we're looking at folks that are subthreshold. And we know that this is actually very common on college campuses, particularly when it comes to compulsive or driven exercise and also self-induced vomiting. Binge eating disorder is one that I think folks are kind of surprised sometimes to learn that it's its own diagnosis, but these are individuals that experience those same binge eating episodes that we talked about in bulimia nervosa, but in the absence of those inappropriate compensatory behaviors. So these are folks that are having just repeated episodes of binge eating, and then afterwards feeling really guilty, ashamed, or disgusted with themselves, going on crash diets as a way to try and remedy what happened with the binge eating episodes. The prevalence here is actually one of the more common ones, affecting roughly 3 to 5% of the general population. And there's a roughly equal sex ratio of 60% women, 40% men, which tends to be closer than some of the other eating disorder diagnoses. And again, this can occur at a range of weights and BMIs. It's not restricted to folks who are underweight, for example. There's another eating disorder that's called Avoidant Restrictive Feeding Intake Disorder. I know these are not particularly fascinating or easy to remember names, but it's a diagnosis that we call ARFID. And these are folks that are characterized by having a persistent failure to meet appropriate nutritional needs. And this can be for a number of reasons. Sometimes folks talk about having difficulty with the sensory characteristics of food. So maybe it's crunchy foods that really bother them or soft foods really bother them. There are some folks also who just report a lack of interest. They're just so uninterested, so unmotivated to eat that they actually end up getting to a place where they can be malnourished, they can lose a significant amount of weight. These might be folks who are basically subsisting on Ensure or protein shakes, those sorts of things. And so oftentimes we'll see this in pediatric populations, and there's a big overlap with folks that are on the autism spectrum, but they're not required to have either one of those in order to meet this diagnosis. And then for everything else that we kind of consider, not meeting full threshold criteria, we have this also very unsophisticated term called other specified feeding or eating disorder. So if you don't happen to meet every single diagnostic criterion in some of the other diagnoses that we talked about, you'll probably be given a diagnosis of OSFED. This is kind of our catch-all category. It, of course, is the most common eating disorder that's out there. Some examples might be, let's say you meet every single diagnostic criterion except for the weight criterion in anorexia nervosa. That might be OSFED. Or let's say that you have all the criteria or the hallmark features of bulimia nervosa or binge eating disorder, but it's only been going on for a few weeks instead of several months that's required for a full diagnosis. That would also be an example of OSFED. And we know, importantly, that engagement in these kinds of eating disorders behaviors is far more common than the threshold diagnoses themselves. In fact, we know that roughly 28 million Americans will struggle with eating pathology at some point in their lifetime. So I'm going to pause there just for emphasis, that before you might have seen those estimates of 1%, 2%, 3 to 5%, and you might be relatively unimpressed and be thinking, well, this is still fairly uncommon for most folks. How often does this really occur in the population? But some recent research that was done suggested that at some point in their lives, roughly 28 million Americans will struggle with some form of eating pathology. That's a huge amount. And that means that you likely know someone in your life that struggled with these kinds of conditions. One of the reasons that we're so committed to detecting people with eating disorders and getting them the treatment that they need is that we know that eating disorders are highly comorbid with lots of other really challenging mental health conditions. So eating disorders are comorbid with substance use disorders. Up to maybe 36% have some kind of substance use disorder as well. Mood disorders are rampant. Most patients that I've treated with eating disorders have some kind of mood or anxiety disorder. And importantly, we also know that eating disorders have the second highest mortality rate of any psychiatric illness. So you might be thinking, how is that possible? Wouldn't depression be more deadly, or schizophrenia, or those sorts of things? But really, when you think about the burden of mental illness, and you think about the fact that these folks have just eating disorder symptoms and thoughts that are predominating their lives, they're putting their physical health at risk. In addition, they may be struggling with substance use, they may be depressed or anxious. You put all of that together kind of in this soup, it's kind of a perfect storm for suicide risk or for mortality risk. And in fact, we know that for suicide risk, the 3 eating disorders that are listed here are actually near the top of a recent study that, well, I guess it's not so recent, but in 2014 that was done looking at all-cause mortality for individuals with different mental health disorders. So, with the exception of these substance use disorders, eating disorders are next, and anorexia nervosa in particular. You'll see at the top that there's postpartum psychiatric admission. That certainly has one of the highest risks, but it in and of itself is not a diagnosis, which is why we say that eating disorders have the second highest mortality rate of any mental illness. And again, when we think a little bit about suicide risk, which is super high for those with eating disorders, we know that these are folks that are already struggling with mental health conditions that put them at risk for suicide. Again, things like mood disorders, substance use disorders, anxiety disorders. But we also know that eating disorders in and of themselves also predict suicide risk. So we're talking about conditions in which people's physical health is very much affected, and their mental health is also put in a place where there are some real extremes. So there was a study that was done a little bit more recently in 2019, looking at the prevalence of suicide attempts across eating disorder diagnoses. So if you think back to that first slide that I had on anorexia nervosa, there were 2 different subtypes. There was the binge purge subtype and the restricting subtype. So you'll see those listed here in addition to bulimia nervosa and binge eating disorder. And what you can see is that the prevalence of suicide attempts among individuals with anorexia nervosa of that binge purge subtype is 44%. Means that almost half of the individuals with this diagnosis have attempted suicide. That doesn't mean suicidal thoughts, it means a full attempt. The next most common would be in bulimia nervosa, where 31% of individuals have attempted suicide, followed by binge eating disorder with roughly 23% of individuals, and then the restricting subtype of anorexia nervosa at roughly 16%. Said in a slightly different way, if we think about the odds of someone trying to attempt suicide if you have an eating disorder diagnosis, these researchers found that individuals with the binge purge subtype of anorexia nervosa were 12 times more likely to attempt suicide than their non-eating disorder peers. Individuals with bulimia nervosa were 6 times more likely to attempt. Binge eating disorder, roughly 5 times more likely to attempt, and so on and so forth. So again, I'm kind of walking you through these fairly dry statistics to kind of drive this point home that eating disorders are serious mental health and physical health conditions that are not only dangerous in terms of the physical symptoms or the medical repercussions of an eating disorder, but also from suicide. So now that we've kind of painted this picture of how eating disorders are serious, but often underdiagnosed and horribly undertreated, I'd like to talk a little bit more about what barriers to care that exist and have created a bit of a crisis for those with eating disorders. So despite the fact that we know that there's significant morbidity and mortality associated with these conditions, only at best, maybe half of individuals with these conditions ever receive treatment. So again, if we're thinking about 28 million Americans at some point struggling, we're saying that 14 million people are going without treatment for conditions that could in fact lead to their death. One of the reasons that we know that there's this kind of poor prognosis for folks is that the longer it is between when you start having an eating disorder and when you actually get detected and then treated, if there's a big gap in between those things, there tends to be a poor prognosis. And I think that most of you that are in this club probably have an understanding of that with most physical illnesses as well. The sooner you can catch diagnoses, the better the prognosis. Because if we can catch it, we can get you into earlier treatment. Usually that means better things for you in terms of the long term. And that certainly is true for eating disorders. But even if folks do get detected, which we know is infrequent, treatment seeking is really challenging. If we think back to those initial slides of the stereotypes of eating disorders, let's say you present to your primary care doc and you say, listen, I've been losing a lot of weight. I feel like my relationship with food is really off. If you don't look like that stereotype, your doc might not screen you for an eating disorder, and you might not ever get the treatment that you need. Or let's say you yourself don't see yourself reflected in some of what's going on out there in the media, you might not even bother to talk to your primary care doc or to your friend or your loved one about what's going on for you. Eating disorders are conditions that are so shameful for people that they really thrive in this secrecy. And so when folks don't reach out for that help, things just tend to get worse. In addition to all of the barriers that there are in terms of just getting detected with an eating disorder, let's say you do get detected, you get diagnosed, you end up getting referred for some kind of treatment, care is incredibly expensive. So there were some studies that were done in the last couple of years looking at the mean cost of different types of care. Residential care, for those of you who aren't familiar, is a type of care that's common for many people with mental illnesses, where you're not necessarily in the hospital, but you might be living at a facility for an extended period of time. They found that the mean cost of this residential care was roughly $30,000 per month. That's more than some people make in a year, right? So when you think about the cost of care, and if you get diagnosed, if somebody tells you it's going to cost you roughly $30,000 a month for treatment, if you are a single mom working 2 jobs and you've got, kids to take care of, there's no way you're going to be able to afford treatment, right? In addition to that, we know that the highest level of care, inpatient care, is also incredibly expensive. So that same study found that the cost of inpatient care per hospitalization was roughly $51,000 per hospitalization. Those are huge costs for the average person to try and bear. And again, to my point about better prognosis, we know that if you are caught earlier and your BMI is higher, there is a 15% decreased cost for every unit increase in BMI. So it's less expensive if you're at a higher weight and you're caught earlier. Again, just speaking to the importance of preventative care and catching folks as early as we can. We also know that in addition to the direct costs associated with getting your eating disorder treated, individuals that have these diagnoses actually end up utilizing the healthcare system at higher rates than their non-eating disorder peers, both 12 months before the eating disorder treatment, before the diagnosis and after. So these are folks that are shelling out money during their eating disorder care, before it and after it. And in addition to that, they're putting a strain on the healthcare system. So again, the longer we ignore this stuff, the worse it tends to get from every level. There was also a study that was done a few years ago looking at the total societal cost associated specifically with adolescent anorexia nervosa. What you can see on the far left side is the hospital-associated cost. So that's that roughly $51,000. In addition, they looked at caregiver cost. So let's say you're a 14-year-old with anorexia nervosa, you have to go into the hospital. We know that as parents, there are certain costs that you're going to have to contribute to that. So whether it's taking time off of work to go and see your kid during visiting hours, maybe it's needing to get childcare so that the other kids who are at home can be taken care of while you're going to the hospital to visit your sick kid. Maybe it's needing to pay for parking, pay for gas, pay for travel, because a lot of these places aren't close by to where you live, right? So if you add all of those things in together, these researchers found that the total societal cost per admission per patient was roughly $54,000 per admission. So we're talking about not only very real dollar costs, but human costs as well. So you might be thinking, okay, so we know that these highest levels of care, like inpatient and residential, are super expensive. Of course, that makes sense because you're getting the highest level of service. These are the folks that are probably the most acute. But what about everybody else who's, in outpatient, working with their therapist or their dietitian, whomever it might be? And certainly those are levels of care that we would like folks to use. The challenge is that so few of us exist. So those of us that specialize in the treatment of eating disorders are few and far between. And so the vast majority of individuals that are out there, let's say you're a therapist here in Chapel Hill, you've hung a shingle, you have an office here in town, most of those folks have never received any formal training in treating eating disorders. So there's a lack of provider education and training that's really necessary in treating these serious conditions. In some ways, I sort of liken it to, if you have cancer, certainly you might start with your primary care doc and you might get referrals, some general tests that are run, but you would expect to be in the hands of an oncologist who specializes in the treatment of cancer so that you can get the care that you need. So imagine a world in which, there's maybe only a handful of oncologists available, not just in your state or in your area, but in the nation. That's the situation that we're in with eating disorders. We also know that even if training is available for providers, if folks are saying, here, we'll train you, we'll get you upskilled on how to manage these conditions, there are a lot of providers who are really uncomfortable with treating these conditions. Unfortunately, they're stigmatized, and a lot of people think, oh, I wouldn't touch that with a 10-foot pole. These are folks that are really risky. They could die on me. I don't want them in my practice. I think also there's this stigma, this idea that, oh, these are just phases, and it's usually these women are just going to grow out of this at some point in their lives. So oftentimes there's also a dismissal of these conditions. But even if you do get folks who are interested in getting trained and they want to work with these patients, training is expensive. Not all providers, not all places have the time or the money to send you to Chapel Hill to do a 3-day training, for example. Many of you may have looked into different trainings or certifications. They're expensive, right? And so that may be a barrier for folks who are interested in learning more. And even if care is available, and I know I feel like I'm painting like a really dire sort of sad picture, but if you guys have questions, certainly we can talk about that. But even if there are levels of care at that lower level that are available, many patients will remain untreated because of so many of the problems that exist in our healthcare system, which I'm sure, given the nature of this club, you all are fairly familiar with, but so few providers take Medicare or Medicaid. And that means that folks that are the most underserved are often going further unserved because of their insurance status. We know that there are not only just the Medicare and Medicaid issues, but also even if you have good insurance, you may be underinsured. So for example, you may have an insurance policy through your healthcare provider, through your employer. But let's say you have a $5,000 deductible. You have to pay out of pocket until you reach $5,000 before your insurance kicks in. That's a huge amount of money for the average American. So it creates a real problem in terms of getting the care that you need. And then above and beyond that, as I mentioned early on, we know that eating disorders do not discriminate, but providers often will, right? So if you also don't have insurance, you'll have a really hard time accessing any kind of care. And that means that people that are more likely to be uninsured or on Medicaid, people that are from BIPOC communities, people that are from low SES brackets, these are the people that often need the most help, but they go without help most commonly. I've said before that there's a lack of specialists in geographic regions, and just in general, there's poor eating disorder literacy. right? So if I were to ask you at the beginning of this presentation, what do you think about when you hear the term eating disorder? What do you know about eating disorder treatment? I know that you all are students, but you probably all have about the same level of understanding that many providers do as well. There's just a real lack of people understanding what these diagnoses are and how serious they can be. There was a study that was done actually just in 2020 looking at the overall social and economic cost of eating disorders. So if I'm bringing all of this together, this is kind of a nice culmination. They found again that roughly 9% of the population, or roughly 28 million Americans, will struggle with an eating disorder at some point in their life, and that there is roughly 1 death every 52 minutes attributed to an eating disorder. That means that once an hour throughout this day, by the time we end this presentation tonight, 1 person will have died from an eating disorder. When you think about that in terms of the human cost, I think it's really poignant. We also know that eating disorders affect everyone. However, people of color with eating disorders are half as likely to be diagnosed or to receive treatment, which I think is also mirrored throughout the healthcare system. And all genders are affected, and all sexual orientations I had mentioned. Then here we get into a little bit of the cost. Now keep in mind that this is a 1-year cost. This is not cumulative over the lifetime. This is just 1 year. This study found that eating disorders cost roughly $65 billion to the US economy. That includes not only the direct care cost of treating these conditions, but if you think about the loss to other parts of our economy. So on the sort of the middle section there, you'll see that the hospital costs might be from ER visits, inpatient hospitalizations, those costing roughly $30 million, $209 million. In addition, individuals and families end up providing 6 weeks of informal unpaid care per year. The government is kicking in money to some of these programs, employers, overall society. So we're talking about a huge cost across the board. And again, I think that people are often surprised by these numbers. I know I was when I saw this, but I think it really drives home this idea that this is a public health issue. This is not something that is circumscribed to a small subset of our population, especially when we think about adolescents with eating disorders, because it means that their families are involved as well. It means that parents are needing to take time off of work, and maybe they're just not as present as they typically would be. So my last point is about primary cares, and this is sort of that little bit of hope at the end. We know that, again, the earlier we can catch these folks, the better. And that's part of why we're so, at NCEED, almost our entire focus is on providing education and training to primary care docs on how you screen for these conditions and how you manage them. And that's mostly because most patients aren't going to wake up in the morning and think, oh, I have an eating disorder, I'm going to go to the UNC Center of Excellence and get treatment. They're more likely to get caught with their primary care doc if they're losing weight or if they're noticing changes in their relationship with food. And this is really great because for many adults, they've had an ongoing relationship with their primary care doc for years. They have a trusting relationship with them. They might feel like they can open up a little bit more. Maybe there's even routine screenings. I'm sure that, as you guys are going to campus health or other places, there's all this kind of paperwork that you have to fill out before you go. And sometimes those screening measures are in there. So it's a great way to try and pick up on folks. Hang on a second. Yeah, okay. And it's really important that these primary care docs are receiving this kind of education and training because they're a crucial part of this 4-legged stool of what eating disorders care looks like. When you're getting eating disorders treatment, you're certainly getting a mental health component, you're getting a nutrition component, sometimes a psychiatry component where they're prescribing medications, but always there's some kind of primary care or medical component where someone's monitoring your physical health. Without any one of those legs of the stool is uneven. It's not steady. It's not stable. And so that's part of why we're so enthusiastic about recruiting primary care docs to do some of this work. The role of the primary care doc can really vary depending on the type of clinic and the type of patient, but certainly there's a role for initial screening, maybe helping to determine based on medical findings, does the patient need to be in the inpatient unit? Are they that sick? Can they be at like a day program? Maybe they can do outpatient. They're also a really crucial part of expressing to patients and families those medical concerns. I have my PhD in clinical psych. I'm not a physician, so I'm not going to be super well equipped to explain all of the medical challenges and the severity of the physical symptoms in the same way that a physician can. Plus, the physician can order lab work, interpret that lab work, help somebody understand how dangerous the eating disorder can be for their heart or their gut, whatever it might be. So they're a crucial part of our team. So with that, I'm going to wrap here and maybe leave time for a couple of questions. But I just want to say that, again, these are the kind of take-home points that I'd like everybody to kind of ponder. And especially if you're on social media at all this week, take a look at some of the messaging that's out there for National Eating Disorders Awareness Week. I think it's a great opportunity to educate yourself, especially if you're aspiring to be in the healthcare field down the road. I feel the same way about eating disorders as I do about trainees. The earlier you can learn this stuff, the better. So I'm really pleased to have been invited here tonight to share some of this with you all. Thanks very much.
Thank you so much, Dr. Peat, for that enlightening presentation. It's definitely so important for us to be cognizant of the stereotypes, how they're not representative of those who have eating disorders, as well as understand the public health impacts of this class of illness and the shortcomings of the healthcare system, especially during National Eating Disorder Week. So CHSS, I will be sending out the attendance form momentarily. So make sure you fill that out in order to get attendance credit. Thanks again, Dr. Peat, and everyone for being here tonight. We'll see you at our next GBM on Wednesday, March 10th. If y'all have any questions for Dr. Peat, feel free to stick around and you can ask those. Otherwise, have a good night.
Thank you.
Thank you. Thank you.
Thank you.
All right, y'all. If there aren't any questions, I'm going to let you get on with your evening. But thanks again for having me. I appreciate it.
Thank you so much. That was an awesome presentation.
Thanks very much. Take care.
Bye.